Welcome to Airway Breathing Conversation, a podcast presented by the Anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for a special trauma rounds this week where Dr. Alena Stirling, an anesthesiologist at the University of Saskatchewan, presents an introduction to the Royal University Hospital Adult Rib Fracture Pathway Pilot Project. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So this is going to be an introduction to a rib fracture pathway pilot that's being launched on the trauma unit at the Royal University Hospital. So it's a very narrow scope pilot just to kind of establish feasibility, really. So I don't have any disclosures to make. I do want to acknowledge that we are on Treaty 6 territory in the homeland of the Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. In terms of the outline of this presentation, I'm just briefly going to review the clinical significance of rib fractures. I'm hoping to discuss interventions that might optimize outcomes, as well as the components of the rib fracture pathways and how we modified them and adapted them to work with our institution. And then I'm hoping to leave some time for questions and discussion. So just a very brief clinical summary. About 10% of trauma patients, or one in 10 trauma patients admitted to hospital, will have rib fractures, and of those patients with rib fractures, about 1 in 10 won't survive. So it is very significant in terms of morbidity and mortality for these patients. And so in the 2000s, there was an explosion of research to try and improve care and outcome in this population. And what the research discovered was that mortality was associated with the number of rib fractures. And so it increased with every rib fracture, but it really increased after about 5 or 6 rib fractures. And mortality was also associated with age. So in the bottom graph, I know it's hard to read on your computer. I'm not sure it'll show up for you guys, but death is on the y-axis and rib fractures are on the x-axis. And the top line is age over 65 and the bottom line is age less than 65. And you can see for every number of rib fractures, mortality was higher in the older population. But once again, both increased significantly after 5 or 6 rib fractures. And they did find if you were over 65, your average mortality, if you're admitted to hospital with rib fractures, was actually 1 in 5. Unfortunately, it's respiratory complications that lead to both the prolonged hospital length of stay, the complications, and the mortality. And if you have rib fractures and you develop a pneumonia, your odds ratio of dying increases by 5. So it's very significant. The causes for and the risk factors for developing pneumonia are multifactorial. So just being admitted to hospital, lying supine, and being immobile are all associated with increased risk of pneumonia. And then on top of that, these patients have rib fractures. They have pain. They might be splinting, have hypoventilating, inadequate coughing, and all this further contributes to that atelectasis and the pneumonia risk. The more significant the injury, the more likely these patients are to have pulmonary contusions, and this is associated with alveolar edema and inflammation and increased secretions that these patients have to clear. And then as well, significant rib fractures may lead to altered chest wall mechanics. This may be pneumohemothoraces, chest tubes. This may be flail segments, which significantly alter the chest wall mechanics, and all of these further increase the risk. So really the key to improving outcome is optimizing respiratory function. We could probably just stop the whole talk here because that's what it comes down to. And this takes a multifaceted approach. You're going to hear that word too many times. It does require patient participation, and it was felt to be important enough that the JAMA patient page published an infographic to help educate the patients that with rib fractures, that it's very important for them to take deep breaths, use incentive spirometry, and stay active. But even with these things, depending on the severity of the injury, it still might not be enough. And the patients may actually benefit from non-invasive ventilatory support, either in the form of non-invasive ventilation like BiPAP or CPAP, or in high-flow humidified oxygen. So if I had to summarize the whole talk, it gets complicated, so I tried to make it simple. It comes down to, can these patients breathe? Can they cough? And is their pain control sufficient enough for them to keep breathing and coughing enough to move and not develop pneumonia? That's the start of it. We'll add to it. So for the pain management optimization, there's a number of different techniques that are employed. We're all familiar with multimodal pain management. Additional adjuvants like ketamine and lidocaine and gabapentin have been looked into. These patients may need oral opioids. They may need to step up to IV opioids or PCA, and they may benefit from regional or neuraxial anesthesia. There's emerging evidence that there are patient populations that might benefit from nerve cryoablation. So perhaps that will also be added in the future. Unfortunately, I wish I could tell you that there was excellent grade A evidence to guide us in what we should do for pain control. But even the gold standard pain control, I'm going to word it that way, the one that should work the best all the time, the epidural, although it showed promise in individual studies, its outcomes and studies have been quite variable. And so it hasn't been clearly shown as the pain management of choice when systematic reviews have been done. So because of this confusion in 2017, the Trauma Anesthesia Society and the Eastern Association for the Surgery of Trauma got together and made some joint practice recommendations. So they reviewed epidural anesthesia versus multimodal and opioids, paravertebral block, interpleural infusions, intercostal infusions, and multimodal anesthesia versus opioids and alone. And unfortunately, for question 2, 3, and 5, they weren't able to make any recommendations. For question number 4, they did conditionally recommend the use of multimodal analgesia based on limited evidence versus opioids alone. And in terms of epidurals, they did conditionally recommend the use of epidurals based on patient preference, because when they completed their systematic review, they actually found that there was no difference between control, which is opioids and multimodal, and epidural. In fact, it trended towards favoring control. They published some guidelines in 2022 and updated their assessment of epidurals. And they added some other questions, including ketamine. They weren't able to make a recommendation for and against on ketamine. And once again, they weren't, even with the addition of new articles, they weren't able to make a recommendation for or against the use of epidural anesthesia in this patient population. They did as well look at, in 2017, some additional, they call them local regional nerve blocks. You'll hear us call them myofascial plane blocks or just blocks. Were described in the literature and were introduced to rib fracture management. And so they also reviewed these blocks. And although there was a trend towards favoring blocks, they once again weren't able to make a recommendation for or against it. So all that might sound discouraging, but I think it does highlight the point that these are really challenging patients to control pain in. This is a difficult issue that we're trying to help optimize, and it gives us a lot of options for optimization. So you might see patients on a variety of different pain treatment plans, and it might be based on contraindications or patient factors. And it might range from a PCA, it might be a block, it might be an epidural, it might be a PCA and an epidural, or a PCA and a block, because the block can't necessarily cover everything. And so it just means that it might not really matter what approach we choose. It's just that we're trying to optimize the pain with whatever mechanisms we can are available to us. So there's one more layer to this. So obviously the whole role of or the whole goal when we're trying to achieve that respiratory optimization, we're trying to ensure they can breathe, we're trying to ensure they can cough and mobilize. We want to make sure their pain control is sufficient so that they can do these things. But even with all of that, for the severely injured patients, some of them will need some support. And so this might, like, as I kind of mentioned before, this might be in the form of high flow nasal cannula, which has been shown in, I'm going to say preliminary studies, but in preliminary studies to potentially shorten hospital length of stay and reduce ICU stay. Or it may be further involving surgical rib fixation or ventilatory support in the ICU. Those might be the types of mechanical support the patient may require. So rib fracture pathways incorporate all these different components of care. And as you can imagine with the things I've just described, optimal management is incredibly resource intensive. And so developing a stepwise approach to both pain management and respiratory support helps focus the care to those who will benefit the most. So the key components are risk stratification component to determine the appropriate level of care, optimization of pain control and respiratory function, and then ongoing assessments to ensure that we're actually achieving our goals and escalating as necessary or de-escalating if possible. So the Western Trauma Association published a rib fracture algorithm in 2017. And their risk stratification was based on age and number of rib fractures. So if a patient had 3 or more rib fractures and they were over 65, you can see they were recommended admitting to ICU. If they had respiratory compromise or severe rib fractures, they went to ICU. I like how this flow diaphragm just goes either ICU, or if they have adequate pain control, you discharge them home. But if their pain control isn't adequate, they get admitted to the hospital for pain control with the goal of ensuring that they can cough, deep breathe, get out of bed if able, and do incentive spirometry. For the patients that are admitted to ICU, there's a lot of arrows that go in many different directions, but respiratory functions optimized by pain management, including a regional block, they recommend, and considering early surgical rib fixation. So a review of the US National Trauma Data Bank of over 20,000 patients over 65 showed that ICU use varied from center to center anywhere from 0% to over 90%. And ICU use was associated with a reduction in composite adverse outcomes. It was also associated with a high over triage rate. So a number which is clearly expensive and resource intensive. So a number of different scoring systems have been developed to try and identify more accurately the patients that are likely to benefit from the higher levels of care and the most likely to deteriorate. Kind of one of the principles in medicine is if there's many different things developed for one goal, probably none of them work well. And that is somewhat true in this case. So you can see their C statistic for most of the scoring systems range between 0.6 and 0.75. They incorporate age, rib fractures, different types of injuries, and some of them even incorporate functional components and radiographic components. The one that I'm going to go a little bit more into detail in is the battle score. So it was introduced in 2014 out of the UK, and it looked at age, number of fractures, chronic lung disease, pre-existing anticoagulant use, and oxygen saturations. And in the UK, so in England, Ireland, and Scotland, they found that the C statistic there was between 0.9 and 0.96, so very impressive. It was also revalidated in New Zealand, and they found it was 0.74, so a little bit less. One center in the US found it was 0.65. And then I couldn't find a C statistic for Italy, but Italy, a trauma center in Italy also assessed this. And they found that a battle score, I'm sorry, I'm calling it a battle score. I'll talk about that in a second. A battle score of 16 correlated with an 80% sensitivity of complications and I said 80, 0.8% sensitivity and 0.87 specificity for predicting complications. So it is one of the better tools we have, and certainly one of the more studied and validated tools. So one of the confusing aspects of it is it's been given about 3 different names. So it was originally called the rib fracture risk score, and then it was called the battle score, and then it was rebranded as the stumble score. So the battle score is the stumble score. Same scoring system, new name. I did want to highlight that there is a different school of thought kind of that prioritizes functional assessment, so frailty screening and actually incentive spirometry to assess how the patient's doing over patient factors. It hasn't been quite as validated. It does make sense that it likely is a very effective screenings tool, but it does require additional resources. So in terms of what we wanted to trial in the pilot, we opted to trial the stumble score. I'm going to try from here on in to only call it the stumble score, with some flexibility to add in a risk assessment for things like frailty. So we went with the data from the initial studies of the UK and then out of Italy, and we chose a cutoff point of 16 for kind of selecting how to manage our inpatients. So if the battle score was less than 16, they could be placed on a low intensity pathway as they were lower risk. And if the battle score was 16 and over, I know it says 0 to 15, but 16 is kind of that cutoff. If the battle score is 16 and higher, they'd be placed on a high intensity pathway. And I just want to take a moment to clarify, although most fracture pathways do also use the stumble score to determine both discharge home criteria and ICU admissions, we really wanted to limit the scope of this just to the admitted patients on the ward because we thought that's who is going to benefit the most from the interventions. And so for the purposes of the pathway right now, it just applies to patients once you've decided that they should be admitted to the ward, and it does not decide who would get admitted to ICU. So it's just admission decisions remain the same. We're just going to use it to determine if they get treatment on a low intensity pathway or a high intensity pathway. I kind of referenced that you'd have the option to consider their functional status. So if you calculate their score and their score is 15, but your clinical judgment tells you that they're very high risk for complications. They may be frail, they may have a low GIS, they may have a high injury severity score, they may have pulmonary contusions, as we talked about. You can upgrade them to the high intensity pathway, even if they didn't qualify for it based on their score alone. And then naturally, I kind of said that although some centers have been using this score to determine ICU admission, our plan is that ICU admissions are based on the patient's clinical condition. So those consults and indications for those consults won't change. we don't have the luxury of just you're over 65 and you have 3 rib fractures, admit to ICU, or you're on 4 liters of nasal cannula, admit to ICU. So we wanted to bring the components of the ICU care that are going to benefit the patient to the ward. So that was our goal in constructing this pathway. So this was a pathway published out of the UK again from the National Health Services, and it was 3 more pages, and we tried to pull the essential components out of it to get it down to a low-risk pathway and a high-risk pathway. So on the low-risk pathway, these patients are admitted. We don't choose their admission bed. That will be determined by you guys on admission, but these are patients that don't necessarily need OBS. So they need regular monitoring, they need respiratory support, physio, PT, intensive respiratory optimization, multimodal pain control, and regular assessment. And if they do well, you can continue your current plan. They could possibly even be downgraded and discharged home, depending on the patient's clinical state. And if they don't have adequate pain control, but they're still doing clinically well, consult anesthesia. If clinically they're deteriorating, they should be upgraded to the high intensity pathway. So now we'll take a look at the high intensity pathway. It includes all the components of the low intensity pathway, including monitoring, respiratory support, physio support, mobilization, multimodal anesthesia, but there's only analgesia, sorry. There's only 2 components of the high intensity pathway that are different, and both of them necessitate an OBS admission. So these patients will go to the observation unit. So the first component is will be put on, it's a trial for feasibility. They'll be put on high flow humidified nasal cannula, and they'll get an automatic anesthesia consult. And so we will choose their type of the type of anesthesia they get based on kind of patient factors, but we'll be involved in their care from the beginning. And then ongoing assessment is very important. If these patients improve, they can be downgraded back to the low intensity pathway, or if they deteriorate, there's not too much more room for optimization, but RT and PT, RT should be consulted, the MRP should be consulted, anesthesia should be reconsulted to see if we can optimize pain. The only thing to step up in OBS is to add in non-invasive ventilation. It's been conditionally recommended by the EAST guidelines, but they do give a caveat about concerns about aspiration risk in patients at risk for that. And then these are clearly patients that are clinically failing and would probably benefit from ICU involvement, if appropriate. And as well, these are patients that are failing, and these are patients that if they have chest wall mechanics issues, may also benefit from a thoracic surgery consult if they meet criteria. So we attempted to summarize that into an order set. So you can see the first page of the order set these are for patients that you've already determined are going to be admitted, and you've already determined that they have rib fractures, they've been confirmed. The battle score will get calculated, and it'll determine whether they're on the low intensity pathway or the high intensity pathway, with an option to upgrade them. And they will have orders for regular monitoring and assessments, automatic consults to PT and RT, mobility orders, oxygenation and pulmonary optimization orders, including high flow nasal cannula and non-invasive ventilation as an option to upgrade. They also will have the multimodal order set and some prophylactic orders. So I know I probably have been calling it the battle score. I know this stumble score can seem quite confusing if you just look at it quickly, but there is great news. So it has recently been added to mdcalc.com. So if you guys want to pull out your phone and pull it up, you sure can. All you have to do is search stumble or battle score on the calculator, and the this will pop up. And so I thought it might be nice to go through some potential patients so that you can kind of get a sense of how the risk stratification will work. So as an example, we'll start with this. We have a 34-year-old female who crashes on her mountain bike and she's otherwise healthy and she has 2 rib fractures. So if you plug in her age, her number of rib fractures, and I'll clarify here because this can be confusion. It's not the number of ribs fractured, it's the number of rib fractures. So if someone has 2 breaks on 1 rib, that counts as 2. So flail chests count as double. So it's the number of rib fractures. Chronic lung disease, anticoagulation use, and oxygen saturation. And then the other question for some of the more severely injured patients is, when are we determining the oxygen saturation level? The initial studies looked at oxygen on admission, presumably not on oxygen. But I would never take a patient off oxygen for this assessment. It's just not worth it. So if a patient's needing oxygen to keep their SATs above 90, just give them a 4. Don't overthink it. Don't take them off oxygen. I know what I was going to say about that. So here you can say, I might have said this already. I might be talking in circles. Here you can see that her stumble score was 9. And I'd kind of mentioned that patients somewhere below, some cutoff points have been 10, some cutoff points have been 12. But patients in this risk category or this degree of injury can often be managed at home. So these aren't patients that necessarily need to be admitted to the hospital for the rib fractures, but they might be in hospital for a different reason with rib fractures. Despite that, you can see that this scoring system will always give you a risk for complications calculated as well. Patients with a battle score of 9, 1 in 10 of them still might have a complication, develop a pneumonia. So I just want to give an example of, this lady is probably pretty low risk, but you can see a 59-year-old with 1 rib fracture and SATs kind of 90 to 94 will also have a low stumble score, kind of 10 points. But let's say he's got cirrhosis, that won't be picked up. Let's say he's got cancer and he's a chemotherapy patient, that won't get picked up. So there still is always that clinical judgment component, and that's probably why there is still a 13% risk, even in these patients that aren't, I'm going to say, severely injured. So looking at some of your other more typical trauma patients, and now I specifically picked examples of patients that might score 14 or 15. So these are patients with this pathway that wouldn't necessarily go to OBS based on their scoring system. So it's like a 57-year-old with 3 rib fractures that's doing well from an oxygenation standpoint. He would go on the low intensity pathway. However, let's say you also look at him and he has some of those components that make you worry, that he's frail, that he's, got pulmonary contusion with it, or other concerns for him. You could always upgrade him to the high intensity pathway if you wanted to. You can see though as well, 1 in 3 of these patients, like this man, will potentially go on to develop a pneumonia. So these are people that we do want to assess. And if their pain's controlled and they're doing great, that's fantastic. But if their pain's not controlled and they're not able to breathe and they're not able to cough, these are the ones that we want to intervene on to hopefully reduce the risk of complications. And just for fun, I plotted in the 65-year-old with 3 rib fractures because that was that ICU admission in some of the pathways. And that gives you that stumble score of 15. So they do correlate. Your risk certainly increases. This is an example of some of the patients that we've had on the trauma unit in the last 4 months, roughly. So we've had a 55-year-old man with, I think, 5 rib fractures and low oxygen SATs. And you can see that his stumble score was 22. And he was actually at a 70% risk of complications. And I should clarify, this scoring system was taken from a retrospective chart review before rib fracture pathways were implemented. So ideally, hopefully, we're going to change that green number. That's our goal. But that's their previous risk. If a 45-year-old man comes in with crush injury and has more than 10 rib fractures, you can see now how you can end up with such a high stumble score. His stumble score was 38, and he was in ICU based on clinical factors. So really, once your stumble score is above 30, you're just at incredibly high risk of complications, and the number probably doesn't, the exact number doesn't matter. This was another patient that was admitted in the last few months, who had 4 rib fractures and was elderly. He did have an advanced care directive and wasn't an ICU candidate, but he had those other aspects of the scoring system. He was on home O2 before coming in, and he was on apixaban as an anticoagulant, which further complicated his care. Presented with a stumble score over 30. So to summarize, so if your patient comes in, they're being admitted to the trauma service, they have rib fractures, you can pull out that little MD calculator and calculate their stumble score to get a sense of the risk of developing a complication, and then start them either on the low intensity pathway or the high intensity pathway. And if they're kind of on that cusp, that 14 or 15, so they haven't qualified for the high intensity pathway, that's that high flow nasal cannula and that automatic anesthesia consult, but you feel like they're at high risk for complications and they have risk factors for morbidity, you can put them on the high intensity pathway. And then these patients will have ongoing assessment, and they can either have their care escalated or they can have their care de-escalated depending on their clinical condition. So one of the things we talked about when we're talking about adjusting care is that patients with rib fractures often have what's been described as a honeymoon period, where if they're in that kind of middle of the road category, not that battle score over 30, but if they're kind of in that mid-range, they often have a honeymoon period over the first 48 hours where they don't look too bad. They look like they're holding their own. But what's really happening is they're hypoventilating, they're not clearing their secretions, and then they develop a pneumonia. And so often a lot of them fail between 72 hours and 5 days if we haven't been optimizing them. And so the idea of this ongoing assessment is if we can detect the patients that seem like they're doing okay, but they're not actually coughing and they're not actually taking deep breaths, if we can get them to a point where they can do those things, perhaps we can prevent the development of pneumonia. And so the pain inspiration cough score is being introduced for rib fracture patients. Sounds complicated, but it's very simple. So we already do the pain score on a scale of 0 to 10, with severe pain being 8 to 10, which we want to optimize in these patients. And then incentive spirometry is conditionally recommended by the EAST guidelines in 2022. And assessing vital capacity, inspiratory capacity, as you saw, it has been used for both risk stratification and for ongoing assessments to ensure that the patient's able to take deep breaths. And so this is the way of assessing that they're actually meeting adequate inspiration to hopefully reduce the risk of pneumonia. And then cough strength, although there are objective ways to measure it, this is just super subjective. Can they cough? Is it weak or is it strong? And so these are measured regularly to ensure that the patient isn't quietly deteriorating and it's not being noticed. Patients downplay their symptoms. Patients, yeah, it doesn't hurt. It's because I don't cough. You know, patients don't always verbalize how they're actually doing. So in terms of anesthesia consults, we can be consulted for assistance with pain control. We should automatically be consulted if the stumble score is greater than 15, but there's going to be information that needs to be conveyed to us. So the patient's clinical status is important for us to know. if we're able to mobilize them and the positions they can take, any spine precautions or any spine injuries we need to know about. If ORs or MRIs are pending is important for us to know about. A lot of our catheters aren't MRI compatible, so we wouldn't want to put one in and then have to take it out. And we need to know their anticoagulation status because that can affect some of the blocks we can provide. In terms of thoracic surgery consults, so surgical rib fixation has been conditionally recommended by the East guidelines, but indications for it, timing, patient selection, and surgical approach are still being determined. And in a lot of centers, it's shared by thoracic surgery, orthopedic surgery, even trauma physicians. Here at our center, the thoracic surgeons are going to take the lead on this. So we'll look to them for their expertise in this area, is the way I will word it. So I did kind of mention that it has been conditionally recommended for patients with flail chest, and in patients that don't have flail chest, recommendations are still, I guess, being determined. I'll word it that way. There's a review of these guidelines happening right now, so it hasn't been updated, and this was published in 2017. So while consensus is being established, times we can think about consulting thoracic surgery include if there's a flail chest that's impairing ventilation, if there's chest wall deformities impairing ventilation, if there's 3 or more displaced rib fractures, if there's radiographic evidence of significant lung volume loss, or if they're ventilator dependent. So those are the patients that it might be worth considering a thoracic surgery consult in, and then they will be the ones to determine if it's an appropriate indication and the timing. So just to review, anesthesia can get consulted for pain control or automatically in the high intensity pathway. Thoracic surgery is consulted if there's indications for surgical rib fixation, and critical care will be consulted based on their clinical condition. And so I know there's 2 times we do mention times to think about ICU consult. So if the stumble score is more than 30, these are patients that are very high risk for complications. And a PIC score greater than 9, if you look at our PIC score and where 3 and 4 are, I mean, these are patients that are on the high intensity pathway. You've already considered non-invasive ventilation. They can't cough and they can't breathe. So these are clinical indications for an ICU consult. And the whole hope of this pathway is that we can bring optimal care to the patients while they're on the ward, and hopefully prevent those complications that lead to increased ICU use and mortality. That's really what our goals are. And what they've found is, I know when I was talking about both the pain control, and even when I'm talking about the rib fixation, and even when we talk about some of the things for respiratory optimization, this is very much like ERAS in that, and I wonder if that's why sometimes the literature is so variable, is if you only apply one of them and not all of them, it just doesn't have the benefit. They all need to be integrated together in order to get the benefit for the patients. So in summary, can they breathe? Can they cough and mobilize? Is their pain control sufficient to keep them breathing, coughing, and mobilizing? It's not enough for them to be able to breathe once and cough once on day 1. And if not, then we need to attempt to improve pain control and optimize respiratory physiology. And that's going to involve PT, RT, is actually going to involve nursing, it's going to involve us when we come in the room and reminding them to take deep breaths. It might involve additional respiratory support, like high flow nasal cannula, or ventilatory support and ICU support, or surgical rib fixation. So just to put the order sets back up there, these will be the order sets that were, or something like this. They're still being revised, actually. So I guess I shouldn't say that. This is a draft example of the order sets. And then on the back of the order sets will be the low intensity pathway and the high intensity pathway, if you want to refer to it as a reference. And it will include the things that anesthesia will want to know if we're going to potentially be adding additional pain control measures. And then as well, there's this resource. So if your patient stumble score is 14 and you're wondering what those risk factors for morbidity are because your clinical judgment says the patient's going to do poorly, we've given some of the possible risk factors for morbidity. If you're wondering if the patient's someone who might benefit from a thoracic surgery consult, we've given the indications for that. If you're hoping to actually assess a patient by a simple frailty score, we've included those questions there. It's quite easy. Do you feel fatigued on a daily basis? Are you able to climb a flight of stairs? Are you unable to walk a block? Do you have more than 5 chronic illnesses? Have you lost 5% of your weight? If you're interested in seeing how they're doing with their incentive spirometry, we've included some goal inspiratory ranges, and we included the PIC score. So there's many references. This might not be all of them. And I just wanted to give a really big thank you because something like this doesn't happen independently. So we've had a tremendous amount of support from the nurses on the trauma ward, as well as physiotherapy and respiratory therapy, and then pharmacy, the anesthesia department, trauma surgery, thoracics, orthopedics, ICU, and ER. So it's really been a joint effort.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.